Very good morning, doctors. Very good morning. I think we are loud and clear. Just 1 minute wait. Just I want to check something. Just 1 minute, everybody. Just 1 minute. It's going on. Yes, I think it's going on. Okay. So welcome to the class. Welcome to the session. So after a couple of time, we are just getting together, right? So I think we previously stopped it. Alternative option for Graves' disease is RAI, radioactive iodine ablation, right? Radioactive iodine ablation. Now, I just want to tell one thing for sure. So, in which conditions radioactive ablation is done? Always remember the first condition is actually patients in which surgical comorbidities are present. This condition, please remember, it is very important. Star mark. Okay. So, patients in which the surgical comorbidities are present, RAI is done. And elderly patients, see, in young patients you should do RAI, but in elderly patients, in young patients you should go for surgery, whereas in elderly patients you should go for RAI, right? And in patients with high recurrence, if the patient even after undergoing for surgery, but still there is a recurrence, still there is a chances of recurrence, then obviously you can simply go for RAI. That is radioactive iodine ablation, right? Now, I want to discuss three important points. What is the anti-thyroid drug of choice in Graves' disease? That is methimazole, right? Now, anti-thyroid drug of choice in pregnancy, that is carbimazole, not prednisone. Why? Because methimazole has some serious teratogenic side effects. What is that? Aplasia, cutis, and choanal right? So, the anti-thyroid drug of choice in pregnancy is methimazole, carbimazole. Anti-thyroid drug of choice in Graves' disease is methimazole, right? Now, anti-thyroid drug of choice in thyrotoxicosis, that is propylthiouracil. What is thyrotoxicosis? There is a sudden release of excess of thyroxine hormones, right? So, why propylthiouracil gives? Because propylthiouracil, it inhibits or blocks the conversion of T4 to T3. That is as simple as like that. You already know that, right? Now, coming to the next condition, what are some of the serious contraindications of RAI, radioactive iodine ablation? One absolute contraindications are pregnancy and lactation. Why pregnancy? Because here the fetus is directly exposed to the radioactive iodine, so it is highly dangerous, so we don't give in pregnancy. And one more thing is lactation. Obviously fetus is consuming milk from the mother, so if mother is given with radioactive iodine, then it may disturb the baby also, right? Now, what are some relative contraindications? What are some relative contraindications? I should keep here. CI contraindications. Relative contraindications include, first one is young patients. We already discussed in elderly patients, RAI is done. In young patients, surgery is done. Why young patients are contraindicated for radioactive iodine? Because there are chances of gamma rays exposure. There is a chances of gamma exposure, right? And in smokers also it is contraindicated. Ophthalmopathy condition also RAI is contraindicated because this RAI ablation can cause gamma exposure in smokers, right? Now coming to the next conditions, that is Hashimoto's thyroiditis. What is the Hashimoto's thyroiditis? It is a what type of disorder it is? It is an autoimmune disorder. It's not a normal disorder like Graves or something, right? Hashimoto's thyroiditis is a autoimmune disorder. So what Hashimoto's thyroiditis is also called as stroma lymphomatosa. Hashimoto's thyroiditis also it is defined with the name called stroma lymphomatosa. Why it was given with the name called lymphomatosa? Because the thyroid tissue is completely converted into lymphoid tissue. Thyroid tissue gets converted into lymphoid tissue. Now, what is the autoantibody you see here? Anti-TPO. TPO means thyroid peroxidase, right? I think I will write here. TPO means thyroid peroxidase. So, there will be antibody against this component, this enzyme, that is thyroid peroxidase. And it is always, and it is sometimes associated with HLA-B8 and DR3 protein, right? HLA-B8 antigen and DR3 protein. DR we already discussed, it is death receptor 3. Now, what is the etiopathogenesis in Hashimoto's thyroiditis, right? The main etiopathogenesis in Hashimoto's thyroiditis is there will be release of autoantibodies against the thyroid peroxidase. There will be release of autoantibodies against the thyroid peroxidase. So this leads to some chain of reactions which leads to conversion of thyroid tissue into lymphoid tissue. So if there is a formation of lymphoid tissue, obviously there will be an initiation of CD4 mediated CD8 toxicity. What are CD8 cells? Toxic cells. CD8 cells are cytotoxic cells. They are cytotoxic cells or also killer cells. CD4 cells are helper T cells. CD8 cells are toxic cells. So CD4 mediated CD8 toxicity occurs. So this CD8 toxicity feature, it leads to permanent destruction of the follicles. It leads to permanent destruction of the follicles, thereby leading to permanent hypothyroidism. Thereby leading to permanent hypothyroidism. So if there is hypothyroidism, then obviously you should give thyroxine. But if it is a permanent hypothyroidism, you should give lifelong thyroxine administration. Now, this Hashimoto's thyroiditis, it obviously increases the chances of malignancy. It obviously increases the chances of malignancy. But which malignancies? Two malignancies risk is increased due to Hashimoto's thyroiditis. What are those two malignancies? First one is papillary type of malignancy, right? First one is papillary carcinoma and second one is thyroid lymphoma. So these two malignancies risk is considerably increased by the Hashimoto's thyroiditis. Now, in Hashimoto's thyroiditis, what are some of the features that we observe? One of the most important features that we observe is hypothyroidism. See, I did not give the image here. We already discussed. Images will be given in the image session. So hypothyroidism, we will see increase in the neck size, that is increase in neck circumference. We see investigations, we do anti-TPO, anti-thyroid peroxidase enzyme antibodies. We will investigate. We will investigate for antibodies against TPO. Now in FNAC, now I should say one statement here clear. This anti-TPO is the diagnostic feature of Hashimoto's thyroiditis. Remember, anti-TPO is the diagnostic feature of Hashimoto's thyroiditis. Please 1 minute. Please 1 minute. Be like that. So this anti-TPO are the diagnostic feature of Hashimoto's thyroiditis. Now one more thing is, you do FNAC. In FNAC, you just see there is an increase in lymphocytic infiltration. While doing the FNAC, you will observe there is an increase in lymphocytic infiltration. And there one more important thing is, there are presence of a type of cells called Huttal cells or Ashkenazi cells. Huttal cells or Ashkenazi cells. Very important statement. Remember, Ashkenazi cells or Huttal cells are seen in Hashimoto's thyroiditis. What is Hashimoto's thyroiditis? It is an autoimmune disorder. Antibodies are produced against which compound? That is thyroid peroxidase, right? Now management is, obviously there will be destruction of follicles, so obviously there will be no production of T3 and T4 hormones. So what you will do? You will give lifelong thyroxine. Why? Because it's a permanent destruction. It's a permanent hypothyroidism. You go for lifelong thyroxine. If there is a presence of malignancy, obviously what you will do? You will simply say the statement काटो, पूरा thyroid काटो और patient को बचाओ. Means what? You just simply do total thyroidectomy. पूरा thyroid को काटो उसको. Okay. Now we'll come to the next very important situation, that is acute suppurative thyroiditis. Acute suppurative thyroiditis. Now, what is acute suppurative thyroiditis? Acute suppurative thyroiditis occurs due to infection. Which type of infection? Suppurative infection, pus-oriented infection. If there is an infection, obviously it may lead to acute suppurative thyroiditis. But most prominently, most common in children, what happened? There will be a persistent pyriform sinus. I think you know pyriform sinus. We will discuss in anatomy. If there is a persistent pyriform sinus, it may lead to acute suppurative thyroiditis. How? If there is a pyriform sinus, if the pyriform sinus gets infected due to some oral infection or upper respiratory tract infection, then obviously it can spread to thyroid. It leads to acute suppurative thyroiditis. Now, this so-called condition here, you will see this pyriform sinus. It actually connects oral cavity to the thyroid. So thereby, if there is an infection present in the oral cavity, it may lead to spreading towards the thyroid region. Now, actually, this acute suppurative thyroiditis condition is rare. Why it is rare? Because the thyroid itself is highly resistant to infection. But why it is resistant? We have some reasons for it. What are those main reasons? It is highly supplied by blood. So it has a rich vascular supply. It has the highest iodine content, man. 90% of the body iodine is stored in thyroid. And one more important thing is it has a fibrous capsule. But if the patient is infected, right? If the patient is infected, wait, I'll tell you. If the patient is infected, that implies the patient is compromised. The patient is compromised. For example, if the patient gets an infection, then it can be said like the patient is compromised. So, in which conditions this condition may be observed? So, in immunocompromised states, acute suppurative thyroiditis can be observed. What are these immunocompromised states? Something like if the patient has transplant recipients, if it is a malignancy condition, if any sort of immunosuppressive drugs like steroids are given to the patient, then obviously acute suppurative thyroiditis may occur. Now, what is the root? It is hematogenous, or sometimes it can be lymphatic also. What are the clinical factors? What are the clinical features? You most probably see pain as well as tenderness, and you can also observe fever with chills and rigor. You can also observe fever with chills and rigor. Now, tell me, what is the management? Management is very simple, because as there is a presence of infection, the only thing you can do is simply go for incision and drainage, that is IND. With it is because it is an infection, that to suppurative, you just go for antibiotics. Now, if you do FNAC, fine needle aspiration cytology, you observe there is an increased neutrophil count. There is an increased neutrophil count. So, for the infection, what you will do? You will go for IND, incision and drainage, followed by antibiotics. But if there is a recurrence, first you have to rule out that there is no pyriform sinus present. But if there is pyriform sinus present there, by doing the test of barium swallow, you can detect whether pyriform sinus is persistent or not. But if it is there, you simply go for excision. Right? Now, coming to the next conditions, that is subacute thyroiditis. Subacute thyroiditis mostly occur due to upper respiratory tract infection. Right? This subacute thyroiditis, it is also called as deep veins thyroiditis or viral thyroiditis or granulomatous thyroiditis or giant cell thyroiditis. Why it is also called viral thyroiditis? Because it's most probably caused by virus. Now, I want to tell you one thing. There is actually a presence of granulomatous inflammation. There is a presence of granulomatous inflammation that is actually present in the thyroid, which leads to destruction of the follicles. Now, listen to this chain, very important. It might come as a stock question in Inicet. So what happens is, these granulomatous inflammation, they lead to destruction of follicles. So if the follicles are destroyed, the T3, T4 hormone present in the follicles, they get released into the stream suddenly. When these T3, T4 are released into the stream suddenly, there is an increase in their levels in the blood. So there will be increase in the blood T3, T4 levels. So obviously it will lead to hyperthyroidism. But after the usage or utilization of this T3 and T4, again the thyroid levels comes to normal. That is called euthyroid state. Now, as these levels came to normal, but already the follicles which are destroyed, that change is temporary. Why? Because the follicles are completely destroyed. There is no returning back. So obviously the patient, whether he stays in the euthyroid or it goes into hypothyroid, as there is no follicles to produce sufficient T3, T4, ultimately the patient will go into where? Patient will go into where? Hypothyroid only. See, as there is no, what is that, follicles for the production of T3, T4, obviously the T3, T4 levels in the patient, they just decreases, they decline. So by that, the person may go into hypothyroid, right? But still remember one thing, this type of thyroiditis, they simply resolve on their own. No need of management is actually needed. They simply, what they do is they resolve on their own. Now, what are the clinical features that we observe here? There will be pain, there will be tenderness due to pus associated with all sort of white blood cells, right? So there is a presence of pain and tenderness due to pus. Now this condition is associated with HLA-B35, human leukocyte antigen B35. Now what is the management of this condition? Management is very simple. You just give NSAIDs, right? You just simply give NSAIDs, as well as with NSAIDs you also give one more thing, that is anyone just drop it down in the comment section. With NSAID actually you give one more drug here. You just drop it down in the comment section, right? Now what these NSAIDs do? They simply help in controlling the inflammation. These NSAIDs, they help in the controlling of inflammation. Now if the NSAIDs did not give sufficient or satisfactory response, then obviously you shift for steroids. If the NSAIDs did not give response, you just simply shift for steroid. Now coming to the next concept, that is Riddle's thyroiditis. So what happens in Riddle's thyroiditis? Just 1 minute. What happens in Riddle's thyroiditis? So in Riddle's thyroiditis, the thyroid gland and the parathyroid gland completely they gets converted into hard woody like thyroid, which in turn is a fibrous tissue. They just simply gets converted into fibrous tissue. Simply gets converted into fibrous tissue, right? Now as the thyroid and hypothyroid both are converted to fibrous tissue, what happens is the thyroid hormone obviously decreases. With the thyroid hormone, even high parathormone, that is the hormone which controls the blood calcium levels, also decreases. Why this calcium levels decreases? Because the parathormone secreted by the parathyroid gland, right? So parathyroid gland secretes a hormone called calcitonin, right? This calcitonin, they maintain the serum calcium level in the blood. Now if the parathyroid or gland is removed, then what happens? The serum, that is the serum calcium levels get dropped down, right? The serum calcium levels get dropped down. So thyroid becomes hard woody like structure, and what you will do, that's investigation of choice. Investigation of choice will be anyone. What is the investigation of choice for thyroid malignancy? What is the investigation of choice? Anyone? So the investigation of choice obviously become wedge-shaped biopsy, not FNAC. I am telling once again. The investigation of choice become wedge-shaped biopsy. Investigation of choice is wedge-shaped biopsy. And one more thing is the management, right? So what is the management? See, the investigation of choice here becomes the management, that is wedge-shaped excision. Wedge-shaped excision. So by doing the wedge-shaped excision, automatically compression symptoms are relieved. For permanent hypothyroid, levothyroxine should be given, and for hyperparathyroid, serum calcium and vitamin D are given lifelong. Okay, coming to the next topic. Just 1 minute, doctors. Just 1 minute. This thyroiditis. Why these guys are not open? Okay. Okay. So now we finished all these disorders, right? We finished all this disorder. We finished Riddle's thyroiditis also. Now we will be entering into very important chapter, that is thyroid parathyroid glands. 1 minute. So just 1 minute. Okay. So let's welcome to the thyroid malignancy. Okay. So starting with the first thyroid malignancy, that is papillary carcinoma thyroid. So this form of thyroid carcinoma is most prominently it is seen in regions or areas where the sodium levels are sufficient. So these are actually papillary carcinoma of thyroid is actually observed in sodium sufficient areas only, right? Now, what is the most common type of thyroid cancer? Most common type of thyroid cancer. Anyone? So most common type of thyroid malignancy is papillary carcinoma, and most common type of thyroid malignancy or most common type of carcinoma which is formed due to long standing what is that, goiter. If there is a long standing goiter, I will raise it. I'll write on here. Most common cancer in long standing goiter. Then the answer will be 250. Then the answer will be follicular carcinoma, not 250, sorry. Then the answer will be follicular carcinoma. Why I am sleepy today, I don't understand, but I am getting very sleepy. Just 1 minute, boys. Just 1 minute. All of you, just 1 minute. Okay, I will come. Just 1 minute. Okay, guys. Okay, I'm back. I'm back. Wait 1 minute. Yes. Okay, guys. So we are discussing papillary carcinoma thyroid, right? So actually, it is most commonly found in iodine sufficient areas, right? It is actually found in iodine sufficient areas, right? So remember, for example, you will be given a question, right? It's a 23-year-old female who is living in in regions or in areas where iodine is sufficiently being provided to the female nutrition or male nutrition or something. Iodine is sufficiently given to the so-called individuals present in that area. Now, if something is asked, then most prominently it will be pointing towards papillary carcinoma of thyroid, right? But if in the question it was given like a place name or a region, for example, North region, South region, Western Ghats, like that. If it was given like that, you just make a sense like most of those regions, obviously there is a iodine deficiency. So obviously you point it out like that. So these points are very much crucial. Why? Because in the history, in the patient history or the complaint history or in the MCQ itself, you will be given with the sufficient information, right? So always remember, papillary carcinoma of thyroid is found in iodine sufficient areas, right? Now it is the most common thyroid malignancy. But if someone asks you what is the most common thyroid malignancy, which is actually seen in a long-standing goiter, then it's obviously follicular carcinoma of thyroid, right? So coming to the papillary carcinoma, what are the risk factors? The first and foremost important risk factor is there is an exposure of low dose radiation in the childhood. That is very important, right? And the second risk factor is TG cyst, that is thyroglossal cyst. And third risk factor is Hashimoto's thyroiditis, right? Now coming to the pathology of papillary carcinoma of thyroid, there will be a presence of papillary projections. This is very much important. Why? Because it is very much important in the pathological images which will be given with the mixing of medicine, that is medicine integrated questions. In that you will be given a papillary projections are seen in the pathological slide of the so-called patient. Now what is the most probable diagnosis? Then it's obviously it is papillary carcinoma of thyroid. And one more very important feature of papillary carcinoma thyroid is orphan Annie nucleus. Orphan Annie nucleus. You know orphan Annie, right? Annie, orphan Annie present in the Scooby-Doo, right? So you will see orphan Annie nucleus, right? And there will also be a presence of dystrophic calcification, also known as, called with a name called Sammoma bodies. Now just remember one thing, you all know this, but I am just revising. Sammoma bodies are also seen in SPM or PSM. What are those? Papillary carcinoma of thyroid, papillary variant of renal cell carcinoma, serous cystinoderma of ovary, and meningioma. In this PSM, we always see Sammoma bodies. Then there are also presence of pseudo inclusion bodies. Very important. Now, what are the clinical features of papillary carcinoma of thyroid? There is actually a presence of midline neck swelling in the anterior part. There will be presence of midline neck swelling in the anterior part of the neck. Now, what is the most common route of spread? It is lymphatics. Why? Because due to presence of level 6 nodes, there is a presence of level 6 nodes near the region. So, obviously, most common route of spread is lymphatic. Most common site of metastasis, it is lungs. Okay. Now, what is the investigation of choice? That is FNAC. What is the treatment of choice? Total thyroidectomy plus removal of enlarged lymph nodes plus you can include or you cannot include. You just do ipsilateral modified radical neck dissection. But when you will do this MRND, modify ipsilateral MRND, you will do MRND if any lymph node is positive. Then you just do ipsilateral modified radical neck dissection. Ipsilateral means on the same side, contralateral means on the opposite side. So what is the treatment of choice for papillary carcinoma of thyroid? You do total thyroidectomy plus removal of lymph nodes, enlarged lymph nodes plus ipsilateral modified radical neck dissection if there is a presence of positive lymph node. Now coming to the next carcinoma, that is follicular carcinoma. Follicular carcinoma most commonly is seen in the 5th to 6th decade. 5th to 6th decade, and it is seen in iodine deficiency areas. Papillary carcinoma of thyroid is seen in iodine sufficient areas, whereas follicular carcinoma is seen in iodine deficient areas. Now, what is the most common malignancy seen in a long-standing goiter? That is follicular carcinoma. Remember this question, very important MCQ. You will be given 21-year-old female having a long-standing goiter since the past 6 years, and now she came with a complaint of sudden increase in size with minimal pain, and there is a no hoarseness of voice, no dysphagia, no dyspnea. Now what is the you think what is the diagnosis of choice? No, that will not be given. You know what is the question that will be given in Inicet? What is the most common route of metastasis? That is the question that you should expect in the Inicet. Like that. Don't expect someone to give you investigation of choice or you management of choice or those type of things. But the Inicet examiners, they will expect most common route of metastasis. Why? Because any doctor, anyone can say like any cancer, you just go for excision or surgery. But what about the metastasis? That is very important because the follow-up is important than the treatment. Always remember, it is not important like you just do the surgery and you leave the patient. No, the follow-up is very important. That will decide the survival rate of the person. You don't do follow-up. See, you heard about something called choriocarcinoma. You heard about something called justice trophoblastic neoplasia. What you will do in all those things? You do a follow-up for HCG. What are the levels of HCG? What are the titers? How much values of HCGs are there? So you do a complete follow-up. Why? Because follow-up is always important in all onco cases, right? Yes, prognosis is also important, but follow-up is the obvious thing. Why? Because we want to discuss about the survival patient. We don't want to think about the patient who is about to die in 2 or 3 days. Obviously, he will die. You do the treatment, he will die. You don't do the treatment, he will die. But what about the patient who has a chance of surviving for another 5 years? He has a chance of surviving for another 5 years. He can bring gold medal to the country. He can bring some change in the government. He can just introduce some new GO in the government, some new policy to the poor people. So it's always better to do the follow-up. So now coming to the question, again, you will be given with a question like a 21-year-old female who is having a long-standing goiter for the past 8 years. She came with a complaint of sudden increase in the size of the swelling as well as there is a minimal pain, but she did not observe any compression on the trachea, esophagus or recurrent laryngeal nerve. So there is no dysphagia complaint, there is no hoarseness of voice. But what is the most common route of metastasis? Obviously, the most common route of metastasis is the first one will be the bones. In the bones, what are the components affected? The thoracic vertebra. The thoracic vertebra, followed by the ribs, followed by the pelvis, and followed by the skull. Okay, you just remember like this, from up to down, from ascending to descending. So first one is vertebra, second one is ribs, third one is pelvis, and fourth one is skull. Okay, we will go like this. Okay, we will go like this. Okay, just leave it up. See, remember, mug it up however it is, but you should remember. But if you ask me what is the most important thing you should remember in this, that is the most common root of max is thoracic vertebra. Remember, right? Now there is a so we'll come into the follicular carcinoma. So it's the most common malignancy and long-standing goiter. And what are the mutations you see in follicular carcinoma? Very, very important. PAX8 or PPAR1, PPAR1, PPAR alpha inhibitors. What are the drugs? Study, revise, remember. P10 mutation, P10 inhibitors. What are the drugs? P53 mutation, P53 inhibitors. What are the drugs? RAS mutation. Very important, RAS mutation. So these 4 mutations are observed in the follicular carcinoma. So what are the clinical features that we see? There is a sudden increase in the size, minimal to no pain. There will be no compression of trachea, so there will be no dyspnea, no compression of esophagus, no compression of recurrent laryngeal nerve. So there will be no dyspnea, dysphagia, and hoarseness of voice, that is called as dysphonia. Now there will also be no lymph nodal metastasis. If there is no metastasis, can you tell me whether you should resect the lymph nodes while doing the surgery? No. No. If there is no involvement of lymph node, what is the point of resecting the lymph nodes? There is no use to in resecting the lymph nodes. So just forget about lymph nodes in follicular carcinoma. There is no involvement of lymph nodes in follicular carcinoma. Now tell me the answer. What is the most common route of spread? That is hematogenous. Why? Because we already discussed there is no involvement of lymph node metastasis. So there will not be any involvement of lymph. Now what is the most common route of metastasis? Bones followed by vertebra. Sorry, bones, that is vertebra, followed by ribs, followed by pelvis, and finally the skull. Now in follicular carcinoma, we see a feature called pulsatile secondaries. What are pulsatile secondaries? Actually, it is a osteolytic lesions and which are hypervascular. This condition is seen in follicular carcinoma of thyroid. But can you tell me what are the other conditions where you see pulsatile secondaries? One is RCC, that is renal cell carcinoma, and second one is the follicular carcinoma thyroid itself. Now what is the investigation of choice? It is biopsy. Why biopsy? Why not you go for FNAC? Why you don't do FNAC? Because biopsy, it can differentiate vascular invasion and capsular invasion, whereas FNAC, you cannot differentiate it. So the diagnosis actually depends on the vascular invasion and the capsular invasion. So for detecting those things, obviously you should go for biopsy only rather than FNAC. So investigation of choice is biopsy, and treatment of choice is total thyroidectomy. Now here we already discussed lymph nodes will not be touched. Why lymph nodes are not touched? Because there is no lymphatic spread. Okay. So until then, we finished the follicular carcinoma of thyroid. Now coming to the next topic. So we will discuss something about, I'll write here, well differentiated thyroid cancer. Well differentiated thyroid cancer. Okay. Now regarding the post-operative management. Regarding the post-operative management of a well differentiated thyroid cancer, it includes actually two types of cancers. What are those? One is papillary type and another one is follicular. We already discussed. Sorry if I am writing here. I mean, if I am writing now, don't think like time will be delayed. We will go smooth, slow, and we will remember most of the content, right? So there are actually two forms, that is papillary carcinoma and follicular carcinoma. Now in this malignancy, we obviously perform what will perform? Total thyroidectomy. We perform total thyroidectomy. Always remember thyroidectomy. Now after performing total thyroidectomy, the patient will obviously become hypothyroid. Hence what you will do? You will give thyroxine replacement life. You will give thyroxine replacement, right? It should be administered. Now coming to the post-operative management, there will be a thyroxine suppression, right? There will be a thyroxine suppression. So how you will suppress the thyroxine? Wait, I'll write here. Regarding post-operative management, we will give high dose thyroxine. We will give high dose thyroxine for 6 weeks. See, this time period is very important. In the recent examinations, I have seen some MCQs revolving around the timeline. So remember, for 6 weeks we give high dose thyroxine. So what it will do? Obviously it will suppress the TSH. What is TSH? Thyroid stimulating hormone. Now if the TSH is suppressed, what happens? It prevents the proliferation of thyroid remnant, right? It prevents the proliferation of thyroid remnant. You understand? So what happens is it suppresses the thyroid stimulating hormone. So after that, what we do is we do a whole body scan, or simply say like whole body scan. Now after doing the scan, so with what isotope you do, everyone? With what isotope you do? Iodine 123 or iodine 131? Iodine 131. Why we do with iodine 131, I will discuss in a short time. So what we have to do is, we will do with iodine 131 isotope, we will do the body scan. Now remember one thing, we have to stop thyroxine. Why? Because we are giving high dose of it. So we have to stop thyroxine, that is T4, for 6 weeks. So remember, stop thyroxine for 6 weeks. Okay. Now let's look some facts behind stopping T4 for 6 weeks. Why we should stop T4 for 6 weeks? Why we stop T4 for 6 weeks is, actually on the thyroid follicles, wait, I'll write here. On the thyroid follicles, we have something called sodium iodide symptom. Sodium iodide symptom. Now this symptom is actually responsible for uptake of radioactive iodine. Uptake of radioactive iodine. Right? Now, for example, these importers are actually under the influence of TSH. Now, whenever TSH rises, they will be increased and there will be an increased expression of sodium iodide importer. For example, if there is an increased TSH, then it leads to increased expression of sodium iodide importer. Now, if there is an increased expression of sodium iodide importer, then there will be an increased uptake of radioactive iodine. Now, can we say that if there is an increased TSH expression, then it leads to increased uptake of radioactive iodine? So, obviously, radioactive iodine depends on radioactive iodine, the so-called scan, this uptake depends on TSH, right? TSH. Now, and T4 has to be stopped to reduce the uptake of radioactive iodine. Why it should be stopped? Why? Obviously, because if T4 is continuously given, then if T4 is there, obviously there will be a feedback inhibition of TSH. If TSH is not there, can the radioactive iodine be uptaken? No, it cannot be absorbed. Radioactive iodine can be uptake, or its uptake is done only with the help of TSH. So there should be an increase in TSH. So if there should be an increase in TSH, obviously you should stop thyroxine before 4 weeks. Now, certain patients they cannot tolerate the symptom. Certain patients they cannot tolerate the symptoms. Which symptoms? The symptoms which are produced due to stopping of thyroxine for, that is T4, for 6 weeks. T4 stoppage for 6 weeks. Then what you will do, if they produce some symptoms after stoppage of T4 for 6 weeks, then what will you do? So in order to prevent that, right here. So to prevent it, what you do is, first you convert, the T4 is switched to T3. Which is active, T4 or T3? Answers. T4 or T3? T3 is active. But which is abundant? T4 is abundant, right? Now T3, which has actually a shorter half-life. Remember, T3 has a shorter half-life. Now if it is a shorter half-life, then obviously it can be stopped for 2 weeks. But T4 has long half-life. So it would be stopped something like before 6 weeks only, right? Because T4 has long half-life, whereas T3 has shorter half-life. So shorter half-life substances, they can be easily be expedited within a short time. So T3 can be stopped before 4 weeks. Can be stopped before 4 weeks. See, you understand or not? Please, if you did not understand, you just read this or you check this once again. See, again I will explain it. Just listen carefully. The radioactive iodine which we give is uptaken or absorbed by the body only with the help of TSH. Why TSH? Because TSH helps in increase in expression of sodium iodide symptoms. Increased TSH leads to increased expression of sodium iodide symptoms. So if sodium iodide symptom expression is increased, obviously the radioactive iodine, which is also a type of iodine, so obviously the radioactive iodine absorption also increases, its uptake also increases. So increase in TSH is directly in relation with increase in uptake of radioactive iodine. Now we already discussed we should stop T4 before 6 weeks. Now if you stop the T4, will the patient land up in hypothyroidism or hyperthyroidism? He will land up in hypothyroidism, severe hypothyroidism. The patient may not tolerate. So what you will do? First you will convert this T4 into T3. And then you can stop T3 4 weeks before the surgery. No need to go for 6 weeks. You can stop the drug just 4 weeks before the surgery. That's something like 1 month before. You understood or not, right? Now, we will discuss the function of whole body scan, right? So before that, we'll discuss some other things. So the T4 is switched to T3 as T3 has shorter half-life. It is stopped not 4 weeks, sorry, 2 weeks. 2 weeks, sorry. It is 2 weeks. Sorry. Stop. My drawing pen is not out. Stop before 2 weeks. Okay, so stop before 2 weeks. Understood or not? Understood or not? Answers. Okay, so before 2 weeks. Now if you come to the next portion, T3, which has shorter half-life, is then stopped for 2 weeks. Thus, TSH starts rising. Why? Because we stop the thyroxine. In response, the body will secrete the TSH in order to absorb more calcium from the blood. Now, suppose if the patient are not able to tolerate the symptoms of so-called hypothyroidism, then what you will do? You will give recombinant TSH. You will give recombinant TSH. Now, this recombinant TSH is actually given before the whole body scan, right? Now, 48 hours before whole body scan is performed, function of advanced whole body scan. What are the functions of whole body scan? First, we should read. Now, actually, what is the function of iodine 123 for diagnosis purpose? What is the function of iodine 131 for therapeutic purpose? But why we have given iodine 131 for this condition? Why not iodine 123? Because iodine 131, it will diagnose and simultaneously ablate the thyroid remnant also. So it makes thyroglobulin a better marker for post-operative follow-up. You understand or not? Now, coming to the investigations, the thyroglobulin should be less than 2 nanograms per milliliter. Post-thyroidectomy, it should be very low amount, less than 2 nanometers, 2 nanograms per meter. Then you do an ultrasound, then you do a chest X-ray. Now regarding the management, you just do radioactive iodine ablation, which is in case of recurrence. Now if any issues are persist, then you can go for PET scan. And what are the indications of PET scan? There should be some evidence of recurrence, which is rising thyroglobulin with normal USG neck and normal CT neck. That's it, right? Now coming to the prognostic indicators in well differentiated thyroid cancer. Just 1 minute. Okay guys, we will discuss prognostic factors and we will just stop there, okay? So we'll just discuss the prognostic factor. Just give me 5 minutes of your valuable time. I will finish off this prognostic factor. This is a simple topic. Don't just try to complicate it. It is just a simple topic, okay? So we will discuss about the prognostic factors. Guys, coming to the prognostic factors. So actually there are three prognostic indicators are actually as three prognostic indicators. Three prognostic indicators. What are the three prognostic indicators? Aim is ages and masses. Okay, so coming to the AMES, AMES. AMES means age, gender. Sorry, I'm talking about the ages. If you come to AMES, what you see is age, metastasis, extrathyroid invasion, and the size. Now coming to ages, age, grade, extrathyroid invasion, and site tumor. Site size, right? Now coming to the MACEs, you see metastasis, age of the patient, completeness of original surgical resection, then invasion and size. Okay. Okay. Now, what are some of the features for bad prognosis? Very, very important, guys. Very important. Inicet stock questions you will get from this topic. So, bad prognosis. So, what are some of the conditions for bad prognosis? If the tumor size is less than 4, if the tumor size is less than 4, and if there is an extra thyroid invasion, extra thyroid invasion. Now, such type of a tumor whose size is more than 4 centimeters. Just 1 minute, I will just rub it up. So these are the two conditions whose size is more than 4 centimeters, and if there is an extra lymph nodal in the region, extra nodal invasion, external invasion. Now such a tumor has a bad prognosis. Now coming to the good prognosis, if the size of tumor is less than 1, if the size of tumor is less than 1 and age is depicted by the parents, and if the age is very less, and if there is invasion present, then obviously you can define it like it's a type of cancer. Now we will just continue with the next class in the next session. I'll just drop it down here. You just revise the notes which you have written. Until then, just goodbye. Thank you. Your wise talk.